Hello everyone. Today we will be talking about the narrative review paper that I've done on recognition of intimate partner violence using telemedicine during COVID-19 pandemic. The outline of my presentation is that we will begin with discussing the Master of Public Health competencies addressed in this paper, and then we will introduce the topic, its public health significance and aim. Then we will dive into methods and results, discuss the limitations, and end by the conclusion. The competencies addressed in this paper are identifying and addressing the negative impacts in social issues implied by public health policy, utilizing evidence-based medicine concepts to update healthcare professionals, and then demonstrating effective communication skills used during telemedicine with vulnerable populations. The United Nations has defined intimate partner violence or domestic violence or spousal abuse as a pattern of behavior in a relationship that is used to gain or maintain power and control over an intimate partner. Violence can take any form: physical, sexual, emotional, economic, psychological, or digital, especially in today's world. And the risk factors for the intimate partner violence are lower socioeconomic status, low education level, inadequate social support system, younger age, unintended pregnancy, financial dependency on partner, unemployment, care and homeschooling of children, increased drug and alcohol use, and previous history of victimization experiences. The public health significance is that before COVID-19 pandemic, the global reported rate of IPV was about 1 in 3 women. During the pandemic, these stay home or quarantine orders were placed for public health safety reasons. However, these resulted in negative consequences of increased distress in victims, oppression and neglection, lack of privacy, emotional toll of isolation, access to safe places in community was also limited, and their coping strategies had been compromised. Aim of this paper is to raise awareness of increasing IPV victims' coping difficulty during this pandemic, help healthcare professionals recognize some of the red flags of IPV when using telemedicine, and discussing strategies to help them prepare and tackle this shadow pandemic. For the literature review, I have used Google Scholar and PubMed, and using these terms, I also limited the article's publication to January 2020 since the onset of COVID-19 pandemic, and it resulted in 429 articles. After reviewing all these articles for the inclusion criteria of women aged 18 years or more than 18 years, articles only discussing the domestic violence, spouse abuse, or intimate partner violence, and the impact on women's health or mental health during this pandemic. The articles were not limited to any geographical location, and the full texts were obtained and reviewed to see only if they were discussing any strategies for public health officials and healthcare providers to deal with IPV during telemedicine. After applying the inclusion and exclusion criteria, the 18 interesting articles were included in this study. The results were that, first of all, we looked at the trends in IPV incidence, and UNFPA estimated IPV incidence to be 15 million globally for every 3 months the COVID-19 lockdown continued. In USA, the 20 major metropolitan cities had reported observation of 20% or greater increase in IPV-related calls. In Vancouver, there was 300% increase in calls. Um, when they looked at the Canada-based IPV crisis line, in UK there were 150% surge within the first week of stay-at-home measures, and France also noted an increase of 30% in police reports regarding IPV during this pandemic. In Vietnam also there were 624 cases of gender-based violence in just the first 4 months of 2020 as compared to 416 in the last 4 months of 2019. In Australia, the study by Carrington et al. Surveyed 314 service providers, and they had reported that their clients with IPV were observing these uptrends in um, not just IPV, but also other risk factors that they had seen in their victims. So the red flags that all the healthcare professionals should be observing or monitoring whenever they are on telemedicine with their patients. First of all, avoidance of any eye contact, wearing long sleeves in summer to hide injuries, the patient complaining or presenting with sexual assault, suicide attempt, overdose, or as a matter of fact, there is a delay in seeking care. All of these, they should suspect that the IPV could be the actual problem that the patient might be dealing with. And the patient's tone of voice, including fearful, reluctant to speak, and evasive, are some other red flags. Suspicious traumatic or unexplained injury on the head, neck, or forearms. Um, Patient with low self-esteem. Patient constantly looking up to the partner for minor decisions while the patient is reporting other psychosocial symptoms, or they're having weight complaints, or they have repeat emergency room visits, are all of the things that healthcare professionals should be looking out for. So in these articles that I reviewed, they also discussed some of the strategies for healthcare professionals. To begin with, we should ensure that the transition to telemedicine visits is as smooth and safe as possible while addressing their privacy and confidentiality. And it is the physician's responsibility to be more flexible with the availability for appointments with these IPV victims. Interestingly, using the no visitor accompanying the patient policy during this COVID-19 pandemic could be used to the victim's advantage, that we should keep in mind whenever we are dealing with these patients. Um, it is generally recommended that all the healthcare professionals screen all childbearing aged female patients for IPV using some of the tools that have been already um, been been used by the professionals even outside and before the telemedicine. Assessing the patient's current knowledge on public health policy updates is also important because the perpetrators could be using this information and misleading their victims into their increased control and power and coercion. Assessing the division of household labor during this pandemic and increased isolation is also important to consider, and it should be investigated during telemedicine. Assessing the psychological health impact and exploring their social support system is also recommended, and providing universal education and appropriate referrals, as always, is the key role for the physicians. Next, discussing the safety plan, including its access, becomes very important in COVID-19 pandemic because of the restrictions that must be explored by the healthcare professionals. And a lot of these articles also recommended that healthcare professionals discuss it with their patients of IPV to delete the internet browsing history or text messages, or save the hotline information under other listings such as grocery store or pharmacy, and create new confidential email account for receiving information about resources or communicating with healthcare providers, using the online training courses that has certification with them for their staff to learn the recognition of IPV is a good strategy that all healthcare professionals should adapt. Being aware if technologists with device security expertise are available and can be provided for remote assistance to IPV survivors is good knowledge to keep on hand, and being aware that digital interventions to help victims make informed decisions are available, such as the smartphone apps like My Plan, I Decide, I Save, and mHealth. Some of the communication strategies that are recommended for the healthcare professionals to discuss with their patients are using headphones during telemedicine interactions and being prepared to switch to general topics such as weather if the patient feels threatened by the presence of their spouse or partner. And this can also be done by mutually pre-deciding some code words. Asking direct questions and avoiding leading questions is important as always with any patient with IPV. Establishing safe words before the transition to telemedicine is the best approach, and those safe words could be "we are out of milk." Now, next, establishing nonverbal signs expressing distress, such as tucked thumb and closed fist hand gesture, flickering outdoor lights, opening of closing blinds, and waving from certain windows for their neighbors to seek help. Upon disclosure of IPV, the provider should acknowledge it, listen, and validate their feelings. Um, Very, very important that we emphasize that violence is never okay and always reassure that help is available. Follow-up with victims and referrals must be done in the form of personal and secure emails as per patient's preference. Some of the limitations in this review were information bias, small sample size, and question of internal validity is there. In conclusion, we can say that the uptrends in IPV during COVID-19 pandemic demands increased preparation by the healthcare providers to address their dynamic needs. While continuing their use of existing interviewing skills, the current shadow pandemic requires an update in their communication skills during telemedicine. Uh, but as always, screening and educating universally is recommended, empowering the patients with available resources and referrals, then responding to the disclosure appropriately and discussing safety as well as follow-up plan is the key. Thank you. And these are my references.